Well, good morning. Last year I presented my preliminary results on this study, and so today I'd like to focus on present some of the key findings as I see they relate to sexual health services. However, briefly I'll discuss a few specifics about the study and participants. As you can see from this graph, participants arrived from a wide range of geographical locations across the Wellington region, and it included all PHOs within that. I chose participants based from a cross-sectional survey I drew from AT pathology testing for men. And cases were selected for semi-structured interviews based on whether they were a high or a low frequency tester, and then they were stratified based upon whether they are male, so they're or female GPs, and then based upon practice size and location. So I think, as you'll see here, we've captured a reasonably good profile of what Wellington is and the kinds of differences of GPs, and as a result I think the findings of the study are quite robust. It is important to remember that sexual health is only one component of a GP's daily workload. As a result, GPs nonetheless conduct the majority of STI tests in New Zealand, and however they do engage less with men. Indeed, GPs in this study may rarely see their male patients for consults directly relating to sexual health. GPs note that in particular young men's attendance at general practice is poor, and are concerned that some young men may not even have a GP. When men do engage, they tend to see their GP when they are crook or concerned, which is, I believe, is quite similar to sexual health services. This is reflected also in the fact that the most common reason for a GP to investigate sexual health is patient concern, so patients are driving the consults. A little bit about risk perception. GPs are aware of the risks, the behaviours and groups of most concern in regards to STI and HIV risk transmission. While GPs note that anyone who is having sex is at risk of an STI or HIV, they are aware that there's a stratification of risk that exists. So, for example, youth they consider to be most at risk of chlamydia, and MSM, a slightly older group, are most at risk for HIV, for example. As I stated just earlier, general practice constitutes the greatest proportion of STI and HIV tests for men. While STI and HIV testing does occur, it occurs at much lower rates than for women. Nonetheless, the pattern of testing conducted by GPs within the CCGHB area is logical and expected. This testing pattern reflects the risk profiles I discussed earlier. So testing is occurring across all age groups, which suggests that GPs recognise that men are at risk, all men are at risk, including older men, and this is supported by GP responses. Testing occurs predominantly, though, amongst the 25 to 44-year-old age group, and the rates of all testing are lower for youth. Inner city practices, interestingly, test at higher rates for STI and HIV, and there's a whole range of reasons surrounding this, which you can read in my papers when I present them. While HIV is rare, GPs conduct a lot of HIV testing, so this is quite positive. So how does that relate to risk assessments? GPs noted that men tended not to be screened or seen routinely and are far less likely to be engaged in discussions on sexual health and in other types of consults. So questioning male patients on sexual health, if it is not the primary presentation, is seen as by GPs as invasive or inappropriate. Therefore, opening discussions on sexual health during a routine consult may be difficult and often not done. And this is due to time within the consult, primarily, appropriate lead-ins to that discussion, or simply having the experience to ask the right questions. this extends, in terms of asking right questions, extends out to the best language or way to phrase a question, how not to be offensive, and the best time in which to ask those questions. As I mentioned, time within consult, appropriate lead-ins to discussion, and asking the right question are the chief obstacles. GPs were quite vivid in their discussions with me, and that they stated that they are taught to take histories and make diagnoses from that. And so, in that respect, they also recognise that a patient's disclosure of risk, of their risk behaviours, is an integral factor and one that underpins the quality of those consults. So, it is also obvious, as a result of this work, that GPs play a crucial role in generating an environment that allows men to feel confident to disclose risk. In this cohort of GPs noted that their manner or demeanour within and approaching a sexual health consult is important to patients' disclosure of risk. On another note, while GPs recognise checklists are useful, GPs are reluctant to use formal checklists or diagnostic checklists, which may impact on the quality of sexual health consults. As a result, GPs rely on mental checklists, which are based upon experience and education, and have recognised limits within the GP's minds. GPs stated that relying on a mental list, they noted that it was something that needs to be updated or revisited regularly. And when you think about it in the context that sexual health consults are only one part of their daily workload, and indeed may not even be part of the daily workload, that not re-engaging regularly with their knowledge and capacity and mental checklists can have significant impacts on the quality of assessment, hence the consult. So risk assessment and testing. Time is not on a GP side. 15-minute consults are perhaps the biggest issue in that they cannot cover everything. GPs are aware that as a consequence of their current testing strategies, they are missing men. And this is because men's poor standard of access, especially for youth, that men often drive the initiation of the sexual health consult, and that there is a possibility that they might not disclose all information. Something that's compounded by the ability of a GP to open discussion on sexual health and the related questioning that results, and that GPs find it, asking the right questions can be difficult. Additionally, GPs recognise that there's asymptomatic nature of some STI, most predominantly chlamydia, and that testing is not routine also contributes to this. Oopsie. What does this mean for sexual health services? The shared diversity of general practice means that GPs may not deal with sexual health on a day-to-day basis, and thus variation in individual approach may occur. And here, I feel that the importance of CME is highlighted. GPs do note that CME and sexual health is valuable, but time constraints and competing issues are problematic. Competing issues in terms of ensuring that they are conducting CME in all the other areas of practice that they work in. So they also recognise that CME is available, but it's sourced from a range of providers, not just sexual health services in formal in-house settings, but from online, from the college, from quizzes that they might take. There's a whole range of accessibility. GPs noted that, and this is across all of the PHOs, that CME is not geared specifically towards men's health. In fact, some of them, or many of them, noted it could better address how to raise or broach the topic and how to pose and ask the right questions. Sexual health services are recognised by general practice as an important and helpful working partners, and they are certainly seen as a source of expert advice and referral for rare and hard to treat cases. And that relationship, which all GPs recognise with sexual health as being exceptional, I perceive it acts to increase GPs' knowledge and capacity. Their ability to pick up the phone and talk with a specialist sexual health service provider about difficult and hard to treat cases allows them to also have the ability to refer confidently on. And so I think those 2 points there is possibly where sexual health services, as a provider of CME and as a source of referral and interaction or relationship, is going to be key for general practice moving ahead for men's sexual health. So any questions I'll discuss later, but I'd like to acknowledge my supervisors, the study participants, and Team Pathology for giving me a wonderful source of data, study funding through the Matt White Postgraduate Research Grant. Thank you very much, the ACE Foundation, and conference funding from my school to come along here to talk to you today. Thank you very much.